Good afternoon, everyone. My name is Leonard Samariba. I'm a doctor of physical therapy and co-CEO of ProFysio Physical Therapy, along with my partner, Dr. John Scafidi. It's our pleasure to bring you today the third installment of our Zoom at Noon series, Solutions for Lower Extremity Arthritis Pain. It's our hope that during this presentation that you'll learn some about the disease process in arthritis, and that you'll also learn some solutions, home remedies and treatment options that you have to relieve arthritis related pain, improve function, and improve quality of life. Before we get started, I just want to take care of a couple of household items. We are going to save plenty of time for questions at the end of the presentation. There's a couple of different options that you have to submit your questions. The first is to click on the Q&A button on your screen and type in your question. We will go in order and answer all of those questions and save plenty of time at the end of the presentation. You may also use the raise your hand function. On our end, we'll see that you raised your hand, and that'll allow you to ask your question through your audio, through your mic. If you have a mic, we'll turn on the mic and we'll be able to answer your question that way and have a dialogue that way. That's also an option. Also, please note, full disclosure, this presentation is being recorded. We will repost the presentation to our YouTube page and other social media outlets so that we can get this valuable information out to as many folks as possible, so that they may also learn some key solutions for arthritis pain and a bit about the disease process as well. Okay, with that being said, we'll go ahead and get started with the presentation. As I said, again, I'll briefly introduce myself. My name is Leonard Samariba. I'm a doctor of physical therapy, proud co-CEO of ProFysio Physical Therapy. I've been, looks like, I'll put that up there, but I've been practicing, I graduated in 2006 from the University of Connecticut. I've been practicing and taking care of patients since that time. I've also done some fellowship training, specialized training in manual therapy, as my partner John, who will also talk about that. And we opened ProFysio Physical Therapy together in 2013 with the vision that we could build a company that would deliver on the promise of high quality care, and move away from a model that's all too common in healthcare, which is a high volume type of practice. Our core values are clinical excellence, unmatched customer service, and collaborative care. John?
Great. Thank you, Lenny. Great introduction. So I'm Dr. John Scafidi, doctor of physical therapy, co-CEO of ProFysio Physical Therapy. I'm very happy and grateful to say that, been able to be open ProFysio for about 7 years with my best friend, and trying to change the way physical therapy, is done in our home area of New Jersey, different than our competitors, and try to run a different model. A little bit about my background. I'm practicing about 15 years, specializing in orthopedics, manual therapy, musculoskeletal conditions. As Lenny did, I went through residency training and fellowship training in orthopedic manual therapy, as has some of our clinicians on the team, trying to better ourselves with an internal mentorship program and growing each other's skills so we can provide a high quality service to what we call some of the cookie cutter treatments that are out there in physical therapy, and tailoring the treatment approach to what each patient individually needs. I also want to say, thanks for joining us, during these challenging times. This is a great avenue for us to be able to get together, share the information we have, even if we're not able to get together in person for these presentations. And you guys can answer questions, and hopefully we can enlighten you to what a little bit more about lower extremity arthritis and what can be done to help live a better life.
Absolutely. Thanks, Sean. All right, so let's get into the presentation. So, what is arthritis? Let's take a look at that. So arthritis is a condition of joint inflammation. It's accompanied by pain, swelling, stiffness, and limited motion, primarily due to the destruction of cartilage. Now, the purpose of the cartilage in your joint is to protect the joint by absorbing shock when pressure is placed on it. So surely if we start to erode the cartilage, which we'll talk about various reasons why that happens, that can lead to issues. Without cartilage, the bones rub together, which can be very painful and very limiting. Let's talk about some of the causes of arthritis. So a fracture or a broken bone or a form of trauma can lead to arthritis and causes a cascading effect of degeneration over the years and can turn into arthritis. General wear and tear. So, how we use our body and our lifestyles and the things that we expose our joints to over the years can lead to this wear and tear process that some of us may be familiar with or may have heard of in the past. Certainly, there are autoimmune disorders that can lead to erosion of the cartilage in the joints and lead to more severe arthritis. And infections such as Lyme disease can also have effects that cause arthritis as well. Body or joint structure, the way one of my mentors used to talk about it, the way you come off the assembly line, the way some of our bodies are structured and built, body type and joint angles sometimes can relate to the disease process, and we've seen that there are some correlations there, and we'll talk a little bit about body type and how it can affect the arthritis disease process, or even cause be related to the arthritis disease process. Let's cover some of the risk factors for arthritis. Being overweight, there's no question. There is a significant amount of research that correlates and I think this relates to some extent to the wear and tear as well. Just conceptually, if you can appreciate that, our lifestyles and, for example, a lot of high impact, high load activity can lead to a more progressive or quicker wear and tear of the joints. So can the load of our body weight, especially on the lower extremity joints, the hip and the knee. So can that accelerate that process. And so obviously, being overweight is one of the risk factors. Previously injuring the affected joint. So you've heard of, I'm sure, ACL tears, meniscal tears, fractures, and we touched a little bit on that before about trauma and how that can cause a sort of a cascading effect of arthritic degeneration over the years. Previous knee surgery, there is some evidence that there's a correlation between having had previous knee surgery and then the acceleration or the development of arthritis in the joint. And using the affected joint in a repetitive action that puts additional stress on the joint. Baseball players, ballet dancers, for example, or construction workers. These are all folks who use their body in a certain way that's very physical, very demanding, and loads the joints significantly.
So some interesting facts, I like throwing these out there, not just to throw facts at you, but when patients find out or they think they have or have a confirmed diagnosis of, the word arthritis, people get anxious and they feel like, oh man, I'm the only one that has this. How am I going to cure this? Especially during these times at home where we're not as mobile. We're assessing our pain more often because we're not as busy, we're not as distracted. So knowing a little bit about this, people understand that it's not just them. According to the Arthritis Foundation, arthritis is one of the leading causes of disability among adults in the U.S. Very close, if not just as high or higher than heart disease. A lot of people don't know that. The most common type of arthritis is osteoarthritis, more of a degenerative condition, which affects an estimated 31 million Americans. By conservative estimates, they say about 54 to 62 million adults have doctor-diagnosed arthritis, which means there are a lot more people who have these type of arthritic conditions that don't have a formal diagnosis.
Great. John, I'm going to launch a quick poll here about the arthritis diagnosis and how many of our friends on this presentation have had that diagnosis. And please feel free to answer. You certainly don't have to. I believe you can submit it anonymously as well if you'd prefer. I'll go ahead and launch the poll, and we'll take just a few seconds to allow you to answer that question. Great. So it looks like the room's split about 50-50 in terms of whether or not our friends on this presentation have been diagnosed with arthritis. So we'll learn a little bit more about that diagnosis process as the presentation goes on. Thanks so much for participating in the poll.
So in regards to work, arthritis is the #2 cause of work disability. Again, secondary to heart disease. You know, one statistic that people always ask the question is, I feel like it's more prevalent in females than males, and it is true, and there's many different theories on it. If it's hormonal factors, autoimmune disease is higher in females. Again, it could be based on rheumatoid arthritis factor and stuff like that plays a role for females to be more prevalent than males. Arthritis limits everyday activities such as walking, dressing, bathing for over 7 million Americans. It's also interesting when people are diagnosed at a younger age and they're saying that it affects people, only, who are retired or the geriatric population, which is not true at all. There's over 300,000 children that are diagnosed, with arthritis. The baby boomer population is at prime risk, more wear and tear over time. More than half of the people affected with rheumatoid or osteoarthritis are 65 years and older. And the most interesting fact is that half of those affected with arthritis feel that there's nothing they can do to help it. I might as well just live with it because it's here. I've been diagnosed with it, which is a very common misconception. There are things that can be done to not necessarily cure it, but to help people live a much better quality of life, which is what we're looking for. So on the next slide, I want to go a little bit into the anatomy of the knee. So if we look at the knee joint here, some of you understand, okay, I understand what this looks like. But if we look at the top bone there, which is the femur portion of the knee, and we look below, we have the tibia there. And if Dr. Lenny can use his pointer there possibly and show where it shows lateral meniscus and medial meniscus there.
I'm going to see, John. I'm going to try. I'm new with the Zoom stuff, but.
There it is. Normally I have my laser pointer during the live presentation. So for this
Virtual.
year, when people say I have a bone-on-bone condition and the physician tells them it's bone-on-bone, where it says lateral medial meniscus here, that wears away over time. It gets chewed away from activity. Pieces get torn off. And then what happens is the true bone starts rubbing on the other bone. People who have arthroscopic surgeries at earlier stages in life, they take out portions of that tissue, which again allows it to wear a little bit more. But I want you to have a basic understanding of what it looks like to have an arthritic condition and why it may cause, some pain there. So on the next slide here, you hear, oh, I'm knock-kneed, or she's knock-kneed, or bow-legged. If you look at the knee to the left here, like Dr. Lenny was saying earlier in the presentation, that the anatomy plays a very big role. The knee joint to the left shows how the bones run straight in a line there, and you could see the space between the two joints of the knee there is pretty equal, which is what I say a normal, healthy knee would look like. Over time with wear and tear, or, like Lenny said, the way you come off the assembly line, the way we're born, we might anatomically, my mother always was bow-legged, so I'm bow-legged. My father always was knock-kneed. You could see in the middle picture there that the inside of that joint, what they call the medial side of the joint, is closed down even more with less space there. On the outside, there is more space. So if you can picture the friction and the wearing and tearing of a joint, that's where we get more of the bone-on-bone rubbing, as opposed to the picture on the far right of the screen is the opposite, where it shows a caving in of the knees with a lot of pressure on the outside part of the joint, where we're wearing out what we call the lateral aspect of the knee joint. Further on in the presentation, we'll get into what things we might be able to do to not necessarily fully correct, but to aid in decreasing pain caused by these type of conditions by working on certain muscles and tissues and whatnot. So if we jump on to the next slide here, the anatomy of the hip, I wanted to show you guys that it's a little bit different. It's a ball and socket type joint where it shows acetabulum there. It shows that this ball sits inside a socket and it rotates around. There's a lot more mobility in the hip joint than the knee joint that just flexes, up and down. The hip joint moves around in multitude of directions. which is where the muscles, the soft tissues around there play a big role in helping out, that joint.
Great. So we'll look at the stages of arthritis, but before we do, if I may, as a sidebar, I'll use myself as an example, and perhaps John, I'm sure you can relate to some extent as well. I mean, I've had my own share of knee trouble, and as I was saying before, a mentor of mine, he used to say, as you get older, you'll become a better doctor because you'll start to experience some of the symptoms that the patients that you treat experience, and myself, case in point, I played a lot of sports that required a lot of jumping and a lot of high impact. I've had my fair share of knee trauma and injury earlier in my athletic career. And when I recently I had to have a procedure on my knee, I am also a little bit bow-legged, and so sure enough, I looked at my own radiographs, and when you look at it, you can see the angle of the knee, which I never really quite noticed that I was bow-legged before. And then as well, I can picture certainly the disease process, and I do have a bit of arthritis there, and so that's the way the story goes. But stages of arthritis. Stage one, mild arthritis is the hallmarks of a mild arthritis on a radiograph are doubtful narrowing of joint space. When we look at it, we'll look at it in a moment. It's not as blatantly obvious. We'll say that there is a reduced joint space there, and there's possible osteophyte formation. And osteophytes are abnormal bony formations in and around the joint space. That happen as a part of the arthritic disease process. Stage two or mild to moderate arthritis, there's definite osteophytes. They're easier to identify on radiograph, and there is a definite narrowing of joint space. Again, more obvious loss of joint space on X-ray. Stage three, a moderate to severe arthritis, is a moderate multiple joint osteophytes. They're not, they're a bit more severe, but not quite as severe as severe arthritis, the osteophytes. A definite narrowing of joint space, some sclerosis, and possible deformity of bone contour. Sclerosis refers to, again, abnormal bony formation that you can see on an X-ray. It'll look, brighter white as the body lays down more bone to essentially fortify an area because it's been receiving too much friction. Stage four, a large osteophyte formation, marked narrowing of joint space, severe sclerosis, and definite deformity of bony contour. So we're basically looking for the same findings, but on X-ray, it's a degree and extent of severity that will help your physician or doctor of physical therapy look at it and identify what some of the findings are that you have and what stage of arthritis you have. And here is an X-ray of a normal knee. You can see there the black nice open space is what you want to see. That's normal joint space. By contrast, when you look at this radiograph, you see a significant narrowing of joint space there. You can also see there's some abnormal bony formation, osteophyte formation there as well. But that's very obvious there. And now we look at a hip. So like John was saying before, a ball and socket joint here, you see this normal, you can see the outline of the nice ball that is the femur going into the acetabulum, and you see the space there between that and the pelvis. And then from here, you can't even identify that joint space, indicating that you have severe arthritis. And you can also see some of the abnormal bony formation there, which you do not see in the normal X-ray. So what roles do muscles play? Excuse me. So muscles around the joint, generally speaking, if your muscles are of normal flexibility, you're going to have less compression in and around that joint during functional activity, and to some extent even at rest. So maintaining proper flexibility is very important to having a healthy joint, helping to reduce the friction to the joint, which can help abnormal friction can accelerate the arthritic disease process. So it's important that those muscles are flexible. Of course, it's also important that we have good muscle performance as well. You see here, tight muscles are bad. Flexible muscles, absolutely a great thing. It'll help reduce compression. We want to try to avoid compression and abnormal friction on an arthritic joint.
Great. Yeah, and as you can see in the picture here, when you talk about ligaments or joint capsule, a lot of patients, in the general public understands, okay, I understand what a muscle is, I see what it is. But if I don't see what the ligaments are and I don't know what a capsule is, those two, they play a role in what goes on. A joint capsule, every joint has this around it. It's an intricate structure of ligaments that encapsulate and wrap around a joint to keep it stable. In arthritis, this capsule becomes scarred, thickened. It becomes less flexible and causes an increase in the stress on the joint and increases the friction just as much as a tight muscle. Sometimes causing that Rice Krispie sound during normal motion. A lot of times we try to stretch, and what we find is we can stretch our muscles actively ourselves or have someone else stretch them. But to start loosening up the capsule and the joint itself with some of the techniques we'll talk about later, it's a real challenge to be able to get that done by yourself. So that capsule causing the stiffness, when we've done this presentation over probably 7-8 years now, when we did it live, I usually give the example. I don't know if you can see. I would give the example of me lifting my arm, and if you could picture, the slack in your shirt where your armpit is. If I grab all that tissue, I don't know if you're able to see my arm here, but if I grab that tissue, if I grab the shirt here, which I can envision as the capsule, I go to lift my arm, it just won't go up anymore. It's restricting me from going up. If we can loosen up some of the scarring or the flexibility of that tissue and the shirt here, what'll happen is it'll allow us to be able to get that arm to come up a little bit higher. If it's tight again, it's going to yank it back down. That's a more simplified example, but it's what happens in the knee, in the hip, in the shoulder, in the fingers when we have stiffness there. And some of the treatment strategies we're talking about in physical therapy can help to decrease some of that, which hence decreases pain, increases mobility, and overall joint function.
Absolutely. So John, before you start this slide, is it okay if I launch our second poll here? So
sure.
Before we get into treatment, we'll just get a sense from the room, our friends in the room, who's had physical therapy before. So I'm gonna go ahead and launch that poll. Okay, great. I appreciate everybody's responses. Looks like you have 83% of the room has had physical therapy before, and 17% has not. So for those who have had physical therapy, some of this may be a bit familiar, and may be able to talk about how we do things a bit differently at ProFysio. And for those who have not, I certainly hope that you're going to learn some about how physical therapy can have a dramatic effect on arthritis related pain. Sorry to interrupt you, John. Just wanted to launch that poll.
Absolutely. A lot of people don't know that physical therapy is an option. Some people have had physical therapy with us, or like Lenny said, at other clinics. So if you have arthritis, diagnosed with arthritis, what are your options? A lot of people think, and other family members tell them, there's nothing you could do. You just got to live with it. I'm getting old. I've had plenty of patients. I remember this one gentleman, first in my career, told me I have OMB and OMK, and I'm like, I've never heard of it before. And he said, I just have old man's back. I have old man's knee. This is what I have, and there's nothing to be done. So that's the furthest from the truth. Doing something about it is what we recommend. Arthritis pain can significantly affect your function, negative impact, overall, quality of life. So what are some of the options? I'm just going to list out some of the physical therapy options. We'll get into more details of those, but that's our area of expertise. Exercise, stretching, custom knee bracing. There are certain type of modality treatments, ultrasound, there's electrical stimulation, there are laser treatments, joint mobilization, more medically graded exercise than just general exercise. There's modifications to your daily activities, how you're doing things, things that you're having trouble with. There might be simple modifications that will decrease the amount of pain and discomfort you have while being able to do those things, or modifications that will allow you to get back to doing those things. It's all the stuff we look at and much more with physical therapy. In regards to pain management, you all might have heard, I'm not going to get into detail, it's not our area of specialty, but our patients, with the collaborative approach that we have at ProFysio and working with pain management doctors and orthopedic doctors, there are things that are done in the orthopedic office or the pain office, such as viscosupplementation. There are all different types of Synvisc injections, series of 3 injections. There's cortisone, steroid injections. And now, over the years, there's more and more research for different types of injectables that can help decrease the furthering of arthritis, slow it down, or help out with the pain and stiffness component. And finally, the surgery component, where they can go in and do an arthroscopic debridement, or just poking a hole, going in, looking around and cleaning out some of the areas, pulling out some of the tissues, possibly clipping off portions of the meniscus that we talked about, or a joint replacement. Not everyone is always ready for that, but it is something that the research has shown that joint replacement in the hip and knee with physical therapy right after, the long-term outcomes are very, very, very successful. And if someone's been suffering a very long time, if they're able to, and it's recommended, and they've exhausted all their options, it is definitely an option that patients do well with. So if we look at joint mobilization, and some people might have heard this term, or they might have heard hands-on therapy, manual therapy, and a lot of practices say, they're a one-on-one practice. But unfortunately, not to speak negatively about it, we just know what we've seen out there, the environments we've worked in the past before we opened up our own business and have our own model, is an exercise model where people come in and they feel like they're in a workout world, just going in, using equipment and working out. And the hands-on component is not there. And if it is, we find that it can't just be stretching or soft tissue work. Joint mobilization, which is a way where we use our hands and use some type of straps, anchors, to be able to stabilize joints so that we could gently stretch the ligaments, the capsules of a joint, open up those spaces, avoiding pain while doing those things, which helps to decrease pain, hence decreasing stiffness, increasing circulation. And what does that all mean for the patient? It allows them a lot of the times to move their knee better, to walk better with less discomfort. Increased range of motion is often noted, after a session of doing this. We're not saying there's permanent changes right away, but it shows that the tissue is pliable. We can mobilize these joints and get things moving to, in a better range, which will hence decrease pain. The doctors of physical therapy and everyone who works with us at our company in all 5 locations are experts in these areas of musculoskeletal dysfunctions and arthritis.
Definitely. I think it's important to note that the effects of physical therapy are cumulative in nature, and so when you go, every session you're making progress. And just as John said, for example, I'm sure John and myself countless times have treated an arthritic knee and performed a particular joint mobilization technique or procedure and restored, say 10 degrees of motion sometimes in one session. Now, what typically happens is the joint may become a bit stiff again, but with every subsequent session, you're making small gains, and your doctor of physical therapy is measuring it. And, 1 week it may be 3 degrees, and the next week it's 6 degrees. And so even though it often feels and does, in fact, stiffen up again, the effect of physical therapy is cumulative. And every time we mobilize the joint and apply the appropriate amount of stretch or strain to that capsule and to that ligaments, we are having a cumulative and positive rehabilitative effect over time.
Yeah, and on that same note, there, it takes time, and a lot of times people's pain starts to go down, but there are other things we still need to work on to make sure they're strong, they've made the modifications, and most importantly, they're able to continue on a program outside of the clinic when they're done to continue staying healthy. And that's one thing I want to touch on, that was never in this presentation before, which is telehealth and what it allowed us to do. It gave all of us in our geographic area no other option for at some time to look into telehealth and treating patients. And what we found is there are plenty of patients who've come back on board who couldn't come back to the clinic because of health issues or it was more convenient. And what we're seeing now is when we're discharging patients, keeping in touch and treating via telehealth on a decreased frequency at times, it keeps our patients more engaged. They get to be corrected on the exercises. It keeps them motivated and accountable. And the direction from the therapist remotely, like we are right now, watching how the knee or the hip is moving or the back or whatever condition it may be, so that if they have pain, they could speak up, we can make the modifications, and it keeps our patients more compliant. We love seeing you in the clinic, but if people could feel better and increase quality of life at home, there are plenty of patients for us to see. We could do those type of sessions where they can continue to stay, pain-free or less pain to function better. So just wanted to throw that in there.
That's a great point. So bracing, bracing for knee arthritis can be effective. It can help reduce pain, and by way of improving joint space. There are braces that are known as unloading or varus valgus control braces. And what you're seeing in this image here, I'll use my fancy pointer. I mean, this is what the brace looks like when properly fit and applied to the knee joint. But if you look at an x-ray and what it's actually doing, this device here, so after looking at an x-ray and deciding which side is compromised, obviously measuring and fitting the brace appropriately, the end result should be an increase of joint space on the side that is more compromised. So if you think of that, again, what we were saying before about being knock-kneed or bow-legged, deciding on x-ray which side is more compromised, which likely correlates with the body type and the angle at the knee. You choose the right brace, and by ways of using simple levers and tension, applying that brace actually helps to increase joint space. And you can see that on x-ray here. So this is no brace applied and joint space. This is brace applied and joint space. These braces have been researched and studied, and they have resulted in a significant decrease in a subjective pain scale. So I'm sure the folks in here are familiar with, on a scale of 0 to 10, how severe is your pain? And so basically a group of folks were polled, with using the brace, what's the effect, on your pain? And there was a significant effect in reducing pain. We think it's because it increases the joint space, thereby reducing friction and compression on an already compromised joint. John, can you still hear me?
Yep, I can hear you.
Okay, I think one AirPod just died, so we'll see. Just flag me down if you stop hearing me. Hopefully it'll go right to computer audio. So John, you referenced this earlier today as well. So medical exercise therapy. Medical exercise therapy is a form of exercise where it's, as opposed to the more traditional or exercise that people typically think of, is resisted exercise designed to improve strength. Now that's excellent, and there's a place and time for that type of exercise. I think what's important is choosing the right type of exercise for the given condition and for the given phase of healing. And that's what we're experts at, and we take our time to determine and properly grade exercise. But there is a time in the arthritic disease process, depending on severity and extent, and depending on how much of inflammation there is at that given time, where we often decide to use a high repetition, low load exercise protocol, where we might ask you to do 3 sets of 15 or 3 sets of 20 repetition of an easier exercise, with the intent being that we're going to help increase circulation, blood flow, and essentially nutrition to the joint surfaces. And that can also be very effective in reducing pain. You still hear me, John?
Yep, I can hear you.
Yeah, okay, perfect. And that can also help reduce pain as well. Great. So we'll go on to
Right.
the next slide there.
I have to note in that picture there from years ago, I don't think I had an ounce of gray hair in the picture. Didn't recognize myself.
Wait, let's go back. Let's see. No, I'm only kidding. I'm just kidding. All right. So let's talk about home remedies, right? And some of the things that we can do at home. So the first step is we gotta alleviate any acute pain, right? There is a better prospect of being able to apply some very simple strategies that can have a significant effect on the condition if it's not very inflamed and very irritated. If you have pain that is 4 or 5 out of 10, or you just recently did something that irritated and inflamed the joint, that can be a little bit more of a challenge. It's possible you may need to get in for some treatment, see a doctor of physical therapy. Sort of what we often describe as hose the thing down if it's really on fire and inflamed, and then from there it becomes a lot more appropriate and feasible for you to manage this thing on your own at home and do some simple things to help improve the condition and the symptoms. Moist heat, I'm sure the folks in here have used moist heat before. Moist heat can be very effective, especially in chronic conditions where it's been chronically stiff, more advanced phases of arthritis, even in phase 1, if there's some joint stiffness and it's been there and it's of a chronic nature. And by that, I mean, you didn't just go for a jog and now it's swollen and it's red and it's irritated, right? It's a different story. That means it's acutely inflamed. That's something you want to ice, you want to take it easy, you want to modify activity. But if it's just sort of you live with an average 2 out of 10 pain, it feels a little more stiff that day, moist heat can be very, very effective. It's going to help improve some of the pliability and flexibility of the muscles around the joint, as well as the ligaments. And just like we talked about earlier in the presentation, if you can create a little bit more extensibility, flexibility of those structures, you're going to reduce compression to the joint surface. Arthritic joint surfaces do not like to be compressed. And certainly ice. And so we've referred at least 2 different times during this slide, if it's acutely inflamed, you just did something, now the pain is more than it usually is for you, that's something you should be icing, even up to 4 to 6 days if it's very inflamed and irritated, but often less than that, to try to, again, hose it down, sort of decrease the acute inflammation. Protecting the joints, joint protection strategies are very important. Important. During any activity, take frequent breaks. That seems like a very, I'm sure, commonsensical and sometimes probably easier said than done thing to do, but it can be very, very effective. It's a strategy that we use with our patients all the time. It's a simple idea. Instead of doing, if you find that your body and your knee does not respond, or your hip does not respond particularly well to walking, 20 minutes, break that activity up. You'd be amazed at what can happen if you break that activity in half. And now you walk 10 minutes, rest for 2 minutes, and then walk 10 minutes again. You'd be surprised at how well you perform finishing the 20-minute walk. And you'd be surprised how well your body responds later in the day and even the day after, in terms of how swollen does it get, or how high does my pain level get. It can be a very, very effective, simple strategy to just break activity up. And this is the same idea. Break the project into steps. Avoid overdoing anything. If you, for example, decide that you want to do a certain amount of gardening on a particular day, you have a new gardening project that you're working on, that's going to require you to be in a squatted position where your knee is hyperflexed, and it's not going to respond very well to that, because the project may take an hour. If possible, break that up, and you're going to find that your body's going to respond much better. You're protecting the joints when you do that. Use larger muscle groups when possible. Here's where, as doctors of physical therapy and experts in movement science and exercise, we can be a huge help, because we can show you how to properly use your body for activities that might otherwise be challenging. The best example is a squat. I think most of our patients come in for lower extremity conditions, and I would say probably a solid 90-95% of them are going to learn how, when needed, you have to do the squat properly, because it's done improperly so often, and adds to increased stress to the joints. So that's an example of doing it properly and using larger muscle groups when possible to accomplish an activity, so you're not overstressing the joints and adding to compression, shear, and friction forces. lift with leg muscles. So we touched on that a little bit. And then, of course, it's reasonable if something seems like it's going to be too difficult. More often than not, it probably is. And asking for help, I think, can obviously be a good strategy and a good way of doing it. Using a cart with wheels to carry heavy things to avoid stressful bending and lifting. Proper footwear. Proper footwear is often overlooked and can have a significant impact and significant effect. That's another area where I think doctors of physical therapy, and what our team would do is look at the kinetic chain, look at your feet, and determine based on body structure. Again, how'd you come off the assembly line? Is there some angle of knee valgus or knee varus or knock kneed or being bow-legged? And then is there some degree of what you may have heard before, overpronation or flat feet? And what's the effect that that's having? In addition, what's the effect of footwear that has no properties of shock absorption or absorbing any compression? It's your ground reaction forces will always take the path of least resistance. If you're pounding the pavement and you're doing it with a pair of Keds, it's going to be very different than if you're pounding the pavement and you're doing it with a reasonable sneaker, with a reasonable arch for your body type, and that's something we can help you determine. And that has some shock absorption properties. You're going to feel the difference, and perhaps some folks in this room have already noticed that in the past.
Great. Yeah. So some other home remedies, aquatic exercise. Now we're in the summertime where if people have pools or have a community with a pool, unfortunately, the gyms, the YMCA's that maybe a lot of you are part of, to do aerobic exercise there, some conditioning in a pool. And the purpose of the pool is the buoyancy of the water, helps reduce the stress on the joints. Sometimes, the temperature of the water will help to loosen up the joints. Less load on the joints will allow you to have less pain, move better. It's also a way to help strengthen the muscles without taxing the joints as much and having pain limit you. It's something that you can get an individualized program where you could talk to a doctor of physical therapy who can say, this is what I think based on your assessment that you could be doing in the pool at this time, and give you the program to go try on your own in a pool and come back and report, what modifications you might need because you're still having trouble with those. Cycling is another option. But cycling, we have to make sure, in our office, we're very big into not having a tunnel vision on anyone's one condition. And that's where I think physical therapy is the most effective, when we can understand that because the person's coming in for the knee and we want to put them on the bike to be able to exercise the knee, we need to take a look to see what's going on with their hip. Do they have a history of a back condition that might be referring pain down into the knee? And maybe that's what's giving them more discomfort that day. So what I'm getting at there is the adjustments on the bike to make up for that your knee is in the correct position. If you're having other comorbidities or ailments, we're making sure it's adjusted so that it can fit. We're not the type of practice where we bring you in and say, just go on the bike and we'll see you in 30 minutes. It's something where looking at you, making sure and bringing up any concerns, because it shouldn't be this painful, grueling process. But if it is pain-free at home with the right setup, a stationary bike, upright or recumbent where you have back support, or an outdoor bike, sometimes even the small bikes that you can put on the floor and pedal, more of a peddler, while you're sitting in a chair, is another great way to lubricate the joints, keep them moving, build muscle strength, and get blood flow to that area.
Great. Some other home remedies. TENS units can be effective for home pain management, and in some cases that's something that can be issued. Knee bracing we touched on, so you using a brace appropriately, and you're getting the correct amount of dosage of using it. It's important that wearing it is done on a sort of schedule, and that that we're paying attention to how the body is responding in terms of pain and inflammation to use of the brace. Home exercise program. So ProFysio, we utilize a very cool dynamic home exercise program. It's not just a piece of paper where you follow reps and sets. It's very interactive and dynamic. It's actually, you can access it online. You're playing videos from your phone, tablet, or computer, and it allows you the ability to interact and message your doctor of physical therapy to give them feedback about how you're performing. It also tells us if you check in, it tells us whether or not you've performed the exercise. So it allows us the opportunity to engage and encourage you. If you haven't done it, let's find out why. Do we need to modify it? Is it too much? Is it not fitting in with your work schedule or your home schedule? It's important that, like John, said, made a great point of saying, we're not tunnel vision. We have to meet you where you're at and where your needs are, right? And so if it's not working for you, we got to tweak it, fine tune it so that it's something that's feasible. Something that you can do so that you can get well. But home exercise program obviously can be very, very effective form of home management. So let's summarize some of the benefits of physical therapy. Physical therapy is a proven solution for arthritis and associated aches and pains. There's no question about that in the literature. We can teach you optimum joint protection strategies, and we talked a little bit about that. An individualized exercise program based on your needs, your body type, your phase of healing, your severity of arthritis at the hip or the knee. All these things are important considerations and should come into the equation when we really talk about an individualized program. And restoring optimal mobility with exercise and manual therapy. Correcting ways to protect your joints, we talked a little bit about that. Avoid increasing pain while enabling you to perform your daily activities. I think that can have a significant effect on quality of life as well. Minimize strain on your joints and slow down the disease process. We'll evaluate you to determine exactly what must be done to restore optimal mobility, relieve pain, allow you to function better and more efficiently. Our goal is to provide you pain relief to help you return to your normal lifestyle and encourage you to participate in an exercise program. Exercise is, is staying in motion and staying moving in some level of activity that your body responds well to is critical. And so, it was one of the important goals is to find that happy medium. What's the right type of exercise and the right amount and dosage of exercise for you long-term when you're done with physical therapy so that you can maintain your status and slow down the arthritic disease process is very important. I think just to make sure, I think we're doing okay on time. So a little bit about us, and you guys have heard this throughout the presentation. We're a practice that stresses quality care, one-on-one attention with a doctor of physical therapy. You believe it's the subtle differences in what happens in exercise prescription and manual therapy when you're taking your time with your patients that ultimately results in optimal rehabilitation outcomes. And that's something that we dedicate ourselves to and we're very committed to with every single one of our patients. We are experts in joint mobilization, bracing, and medical exercise, and the other treatment strategies that we've talked about today. Amongst our team, there are, I want to say, everyone has some specialty training in these areas. And of course, in a moment, we'll get to some questions. Just a little bit about our locations, Aberdeen, East Brunswick, Edison, Homedale, and Old Bridge. As John alluded to before, we are now seeing patients via telehealth. It's been a fantastic addition to our service offerings for our patients. We're very proud of the work that our team has accomplished and done using this form of treatment. We've been able to think outside the box and get some outstanding results when perhaps, a year ago, I think folks may have had some skepticism about whether or not you can actually have those kinds of results via this remote mechanism. So we've been pleasantly surprised, as have our patients. So it's been a fantastic addition, another great way for us to achieve our goal of improving access to good care for our patients. There's no prescription required to start physical therapy. A lot of folks don't know that. You do not need a prescription from your physician to begin physical therapy. We do offer complimentary transportation. There is some exclusions that apply. So we encourage folks to call the office to get more details on that, to see if it's a service that would be available for you. And we do offer complimentary in-person and video consultations for those folks that may be a little bit on the fence or may have some reservations about whether or not physical therapy is the right option for them. We've always felt that, well, why not just come in, sit down, let us talk to you about your problem a little bit, and tell you a little bit, about how we can help you. And from there, you may be able to make a more informed decision about whether or not physical therapy, or perhaps just working on it at home, or seeing an orthopedic surgeon, or some of those options are, and help you make a decision. Our website's there at the bottom, ProFysioNJ.com. And let's take some questions at this time. So go ahead.
I saw earlier in the presentation, a common question we get, and one of the questions we got today was, can leg pain come from your back? And we've heard that a lot, and you hear a lot of that same thing. Can arm pain come from the neck? And the answer is definitely yes, and definitely both can be going on at the same time. And people say, how? I say it's the same as stubbing your toe and jamming your finger. You could have both going on, but the thing is, your body might perceive one more than the other when it's more uncomfortable. And that's where having the expertise of someone who can take the time to look at what's going on. You might have 10 years worth of knee or hip arthritis, but you're not realizing that the way it's presenting at that point in time is it might be referred from another region. It could very well be referred from the back. The hip can refer down to the knee. So a thorough assessment to take a look at what's going on. And even during the episode of care, we've had patients, I've had them over the years where they have a total knee replacement. And because, the way they're walking after the knee replacement and compensation, they tweak and irritate their back. And if we are so tunnel vision on treating the knee, it could very well irritate the back. And until we calm, say, the lumbar spine down, we can't make the progress we need to on the knee. So, and that's where tailoring that treatment approach to that individual person's need, I think, is the biggest thing that lacks in our profession as a whole. Sometimes is that we go down a path and it's very cookie cutter for every single patient. When in our office, we stress the importance of, we need to look outside the box and try to figure out where it's coming from, collaborating with the medical practitioners that we work with to say, maybe we do need a workup on this area. Sending a text message or a phone call or an email to the doctor, the physician that they have, if they came in direct access or if they came in from a referral from a physician. Having that communication, get the right workup so we can identify exactly where it's coming from. But that's a very common question that we do get. Hopefully that answers your question there.
Great, thanks, John. Looks like, I thought I saw, let me see, one person had their hand up. Yes, okay, so I'm gonna go ahead and turn on the mic for you. Okay, your mic's on, or it is on now.
Is that it? Can you hear me?
I can. How are you?
Okay, good. How are you?
Well.
I had the pleasure of meeting you and your staff many years ago when you first opened.
Yep.
And my knee has degraded, and now the other knee is involved after an injury many, many years ago, to the point where I'm now bone on bone. I have been turned away multiple times for knee replacement because of my lifelong obesity. So I'm still searching for other ways to mitigate my pain. One of the things that will exercise in any way help me, and because it is bone on bone, but somebody told me about a new field in physical therapy with the physical therapist works with flashcards in neuroscience to retrain the brain to not automatically anticipate the pain. Like when you wake up in the morning and you put your legs down and you know your knees are going to hurt, to try and mitigate that.
Sure.
It's brand new. Somebody out on Long Island told me they began it through their physical therapy location. I'm wondering if you have any, have you ever heard of it? I understand it's brand new and
Sure. Yeah. So number one, I really appreciate you tuning in and for the presentation. Thank you for the question. It's a great question. I believe what you're referring to is an area of treatment surrounding pain science, and there's been a lot of emerging literature and research that supports basically the idea that we can retrain the brain and the perception of pain using different strategies and techniques. In fact, one of our associates, our director of clinical operations, Dr. Zach, did a presentation on this. He did our first. It's actually on our YouTube page as well. If you wanted to visit that and watch that presentation, it was the first of our Zoom at Noon series, and it was about perception of pain, and it was about pain science. And although I don't believe it covered specifically the form of treatment that you're referring to that may involve some flashcards and things like that, I think it did talk about the concept of pain science and how it works, and then how we can use some treatment methodologies to try to do that, to manage pain and reprogram the brain and its perception of pain so that you can improve quality of life. We have looked into some more formal treatment mechanisms and form of treatment delivery when it comes to pain science. We are still considering the addition of a virtual reality mechanism that would allow for some of the same learning to happen that I think you're referring to, via flashcards, but it would happen via a virtual reality system.
Mm-hmm.
So it is something that we're considering, but I can't say that specifically that we're offering that form or mode of treatment at this time. I believe that is what you're referring to, John. I don't know if you have additional input in what you've heard in the area of pain science, and in particular the strategy of treatment that she was referring to.
Yeah, and my input there is it has been discussed more and more over the years for arthritic conditions, or chronic conditions, neck pain, back pains, bad motor vehicle accidents, even small incidents of pain or surgeries that went bad, and the brain is perceiving things, and you have a hypersensitivity. And technology is starting to catch up there. There's a lot of companies that are pushing out some great VR, virtual reality stuff, where it really helps to reprogram the brain, starting at the pain, from the pain standpoint. That's getting out there. Dr. Lenny, myself, and a lot of our practitioners, probably about a year ago, demoed a program, brought it into the practice ourselves, and had our clinicians demo it and see what we thought about it. And it's in the early stages, and I think what's happening now is they're talking about it a lot in the research. Everyone in school and a lot of our journals are talking more and more about it over the years.
She just,
a lot of,
yeah, her physical therapist said it was brand new and they had just brought it into their practice out there.
Sure.
And she mentioned it to me thinking maybe it was something I might want to look into. But the other part of my question, do you still think there are exercises that would help mitigate even a bone-on-bone condition?
I think that there may definitely be some exercises that can be beneficial, but I think, again, that we alluded to the idea of individualized care, and we made reference to that's got to depend on the severity and the extent of arthritis, the severity and the extent of inflammation, if there's acute inflammation in the area, and many other factors. So I think in your particular circumstance, it's possible, but it's something that should be examined first, and the exercise should be carefully selected, prescribed, and then it should be carefully followed. Again, John alluded to this earlier. I mean, this is not, we don't want our patients to just engage in exercise and not be monitored and supervised and perhaps cause more irritation. So it's something I think needs to be carefully prescribed, and there is a potential, but it's something I think needs to be evaluated for us to truly, make that determination. There are other options in terms of medical care when the pain is so profound that you can't get to a point where you can even do some of the therapeutic things that need to be done, whether it's manual therapy, therapeutic exercise. That's where I think the way we collaborate with, for example, our pain management physicians that we partner with, that work with our patients, things like peripheral nerve blocks, and again, it's not my area of expertise, so
Right,
I would
right.
broach whether or not that's appropriate given other medical history and whatnot, but they would be the right folks to look at the situation and say, if you're a candidate for a peripheral nerve block or something like that can be done, that now creates a window of opportunity, perhaps, to do some things rehabilitatively, to make things a bit more manageable, maybe improve quality of life and things like that.
Is that the nerve ablation ads that I've seen in the newspaper? Is that what that is?
Nerve ablation is done more is more often occurring centrally, I believe, as opposed to a peripheral nerve block. John, would you agree with that statement?
Yeah.
Yeah. So a
Okay.
peripheral nerve block is not done centrally, I believe.
Okay, no, I see all these things advertised, and do you set up appointments where we could have a one-on-one evaluation virtually? Because I have not gone anywhere under this pandemic condition. I haven't.
Of course. We absolutely do. Yep. We evaluate our patients. We've treated, I don't know the number, but I mean, this is a lot of what we've done during COVID is evaluate our patients, via telehealth when they cannot come to the office or do not feel comfortable or they're not appropriate because of past medical history, so on and so forth. We evaluate via telehealth, and then as I was saying before, we think outside the box and come up with the best treatment plan or treatment approach given the circumstances. If we can't see you in person,
Right.
can't physically put our hands on you, let's do the best we can remotely, or at a minimum, get the opinion of a doctor of physical therapy about where you go from here or what we could potentially do under the circumstances.
Okay, thank you.
Of course. Thank you. I appreciate appreciate attending, and I appreciate the questions.
Great. So another question we have here. There's someone with lower spinal stenosis, in the lumbar spine, stiffness, some more details of, cluttered spinal nerves that cause throbbing in the calves, having arthritis in the knees and ankle that causes swelling, and it's difficult, to walk. And two questions there, and one of them can be can what we talked about today help? Again, there are things going on, and everyone's condition is different, and putting those all together to see what is truly potentially causing more of those symptoms, and it could very, very well vary. I think a thorough assessment and making sure that getting the proper workup, not just in physical therapy with the right examination, but also seeing what the medical history is and seeing what type of workup by a physician with these type of conditions, because there are things such as neurogenic claudication where a nerve, gets compressed and causes a tightness, a throbbing, in the calf. But there's also vascular components where someone can have some type of compression there that can cause these type of fatigue and aching. But arthritic conditions can do the same. So I think the best thing is having an evaluation, talking about, okay, this is what's going on. And then the doctor of physical therapy being true and honest to say, this is what the path I think we can go right now. Or, what, it's great we had the evaluation. Maybe that person is not a candidate at that time for physical therapy, but a scheduled follow-up for 2-3 weeks out, and a plan of a referral out to whatever specialist that we think would be best to do the workup to make sure we're looking at the right causes here to overall achieve the goals of, if I can't walk as much and I have this swelling. Because we always say, you want to be treating the correct thing. If you can't get it on your diagnosis, you have to be open to a collaborative approach for someone else to look at, imaging, ultrasound, other tests. I can't speak to if the person with a question would need to have any of that, but these are just the symptoms. But by talking about their case, seeing what they've had before, I think as physical therapists and doctors of physical therapy, we have the unique advantage of spending time with our patients. And spending the time with the patient allows us to pick a path of where we need to go. Unfortunately, some physician models have a snapshot of 5 minutes, I got to get to my next patient. They barely hear you out, review the paperwork, and you don't get to explain your whole story. The benefit of us and the collaborative approach we have with the physicians we work with is we could take the time to say, you know what, let me get them on the phone and explain what I saw in my evaluation. And what do you think about going down this path, and enlighten them a little bit from, professional to professional is how I'd answer that question. So setting up, an appointment to figure out what path to go down. The second question there was, have you heard of dry needling? Yes, we have. It's a little bit of a sore subject because, we invest a lot of time in training myself, Dr. Lenny, and a lot of our practitioners, and using it. I can't remember how long ago it was when we had our patients advocate. I don't want to throw a number out there. I want to say maybe 2-3 years ago.
I was gonna say about 2 years. I think it was
Yeah,
about 2 years.
where we had some physicians, acupuncturists, and other boards went out and fought, politically, and said that the safety of physical therapists doing dry needling was an issue, and it became something in the state of New Jersey where we cannot practice dry needling despite having training in it. So yes, we've heard of it. We'd love to have it back. We had great success from pain standpoint, nerve pain, conditions that we had trouble treating, and sometimes the physicians had trouble treating. And it is different than acupuncture treatment. I think our knowledge of the body, the anatomy, the physiology, the interactions with medications and whatnot, how we use dry needling in combination with what we do from a regular treatment standpoint, really elevated the treatment approach. But unfortunately, it's something that that no one can practice, at this time in the state of New Jersey. Hopefully that answered that question there.
Great. Any other questions at this time? I'd be happy to answer, of course. Looks like that might be. John, do you have anything on your end? I don't have questions on mine at this point.
No.
Okay. Well, fantastic. I really appreciate everyone who attended the presentation. It's always a pleasure to connect with members of our community and to try to educate in a way that may help you improve your health and wellness is the goal and the objective of these seminars and presentations. It's great that we can connect with people and do it so easily in a way that's so easily accessible for you. We are going to be trying to do this on a routine basis, so please check out our Facebook page to look at upcoming presentations and seminars. And I just want to remind you, we will be taking this presentation, we'll rebroadcast it on Facebook and as well as our YouTube page. So if you go to YouTube and you just search ProFysio Physical Therapy within YouTube, you'll find our channel or our page. And if you click on that, you'll find a number of different helpful videos and tips. Some of the video blogs that our doctors of physical therapy have put together. For example, Dr. Lilly did a fantastic one on proper workstation ergonomics and how to set yourself up for success when you're working remotely, during COVID or any other time for that matter. So things like that. And then of course, this presentation we'll post to our YouTube page. So if you wanted to watch it or there was something that you missed, or you wanted to share it with someone else who may benefit from it, by all means, please do. I want to thank you again for attending. It's been our pleasure, and we look forward to seeing you in future presentations.
Great. Thanks so much for joining us, guys. You guys have a great rest of the day.